I'm going to switch to his right side. When we're talking about scapula, the important things to look out for here are, number one, both inspection and on palpation is the spine of the scapula. And the spine of the scapula can be appreciated as a bony prominence that is somewhat medial and then courses lateral out onto the acromion. Above the spine of the scapula, you have a prominent rotator cuff muscle above the spine known as the supraspinatus. And that would be located right around this area, the supraspinatus, a very important rotator cuff muscle. Below the spine of the scapula, you have the infraspinatus. Below the spine, infraspinatus. It is an external rotator cuff muscle. When we talk about, go ahead and turn around for me again, Sal. Other planes of motion that we need to highlight are at the wrist. If we can go back down to the wrist, would be particular range of motions that we should talk about in terms of total degrees of range. And the numbers aren't really as important as just to get a sense of what is normal range for that individual patient. And a really key component of this, I think, is always to compare range of motion to the opposite side. We always have a saying in medicine that God gave us two so that we can compare one side to the other. Really, when we talk about wrist, we're talking about the sagittal plane motion of flexion as well as extension. So that would be flexion down to about 90 degrees, and extension is a little bit less, to about 70 degrees. We also have what's called radial deviation. Radial deviation is when he would bring his wrist or his thumb closer towards his body in that plane, and then ulnar deviation is out about that way. I can demonstrate that a little bit better if we let his hand drop down to his side. Radial deviation, when he brings his thumb towards the body, is about 20 degrees, and then ulnar deviation at about 55. You can see you get more ulnar deviation than you do radial deviation. The other motion that we highlighted briefly with the elbow was supination and pronation. He's already in a pronated position, and then you can get almost a full 180 degrees motion, which is supination. Each of those are about 90 to, you can get about 90 degree of motion from neutral to supination, 90 degrees of motion from neutral to pronation, for a total of about 180 degrees. The other important thing when talking about inspection of the elbow is something frequently referred to as the carrying angle. The carrying angle is actually formed by the ulna with the end of the humerus, or the end of the humerus, I should say. And frequently it's the angle that is taken if you drew a line between his humerus and his ulna. It would form, and divided that intersection, you would form an angle. Frequently that angle is about 10 degrees. In women, sometimes it's a little bit more at about 15. Sometimes, particularly in women, if they have an increased carrying angle, that's sometimes referred to as cubital valgus. Nothing that you need to know for now, but just so that you know, men have a little bit smaller carrying angle than women. When we get up to the shoulder range of motion, I think, is very important because really the shoulder is one of the most mobile joints in the body, probably the most significant in terms of mobility. We talk about sagittal plane motion at the shoulder with flexion, and you can get about 180 degrees. Go ahead and Sal, raise their arm all the way up. You'll get about 180 degrees, and some of that is combined with scapular motion as well, but predominantly glenohumeral. You can bring your arm down, Sal. And let me have you turn about 90 degrees facing the other way. The other motion other than flexion would be extension. And extension is extending behind the body. Again, it's still in the sagittal plane, and we get about 60 degrees. If you have them turn 90 degrees this way for me, Sal. The next plane of motion, as I demonstrated at the beginning of the tape, would be abduction, which is a coronal plane motion, which is out to the side. And you can get about 170 degrees, almost full overhead motion in terms of abduction of the glenohumeral joint. And come on back down. Again, this is coupled with scapular rotation as well. Adduction is kind of a difficult way to describe adduction, but it's basically bringing the arm to the body. You can describe it in this fashion, or more commonly, people describe it in the horizontal or transverse plane, which is bringing the arm across the body. And in terms of the shoulder, this is what we more frequently refer to as adduction, although both motions truly are adduction. The next are rotation. Rotation is a little bit complicated. There's different ways to evaluate for rotations. I personally do it with the elbows at the side, with the elbows bent to about 90 degrees. And then what I frequently ask the patient to do is to try to act like their arms are gates and to externally rotate their arms as much as possible. You can see that he has about maybe 30 or 40 degrees of external rotation in this fashion here. The next way to evaluate would be, the next plane would be internal rotation, which is again a transverse plane motion, bringing the arm to the abdomen. Another way of checking internal and external rotation would be to have the patient put their hands behind their head. So Sal, let me go ahead and have you do this. This is a combination of motions, which is really abduction of the glenohumeral joint as well as external rotation. So that's one combined motion. That's one way to check it. Another way to do it would be to do internal rotation with adduction. And that's by bringing your hands behind in the handcuff position, so to speak. So Sal, why don't you go ahead and turn around for me. If you can bring your hands up on the small of your back. So this would be adduction and internal rotation, which is, again, a combined motion. The last way that I evaluate rotation, come on, turn around again for me, Sal, would be having the arms, once again, in 90 degrees of abduction. And I think this probably is a good way, particularly with the patient supine, is having them lay down. You've stabilized their scapula in this position, and you can have them do internal rotation, kind of like the scarecrow position. Be careful, because sometimes this has caused pain in patients who have impingement syndrome, something you will learn about as a clinical diagnosis, as well as external rotation. This also can be somewhat concerning, because if people have an unstable shoulder, you can cause them to have increased symptoms with this. So internal rotation and external rotation is another way that you can do this. We're going to carry on next with screening examination of the spine. I think just to model this similarly to the rest of the physical examination, we want to do the same things, which is inspection, palpation, and then range of motion, and then any specific tests that you're going to learn in later labs. So for the cervical spine, we're going to start out by just inspection, and really you're looking for any gross atrophy that may occur. Again, when you examine things, you can't really examine them interdependent of each or independent of each other. They seem to be related. So although the scapula is here, I may look for atrophy of his rhomboids or his trapezius or any of the rotator cuff musculature that he might be having. When we look at the cervical spine, one thing that becomes fairly obvious, especially when you have patients bend their chin to their chest, I'm going to have Sal do that for me, and what becomes very prominent is the process of the spinous processes of C7, and that's very pointed out here and highlighted as a very bony prominence here. You can go on and palpate T1 and T2. Some of the spinous processes, most of the spinous processes are fairly well easily palpated in the spinous or in the spine. And then Sal, let me have you bring your head back. As he extends back, go ahead and extend your head backward. You go into more cervical extension. And here you're going to lose some of those spinous processes just because of the position and the anatomy. Go ahead back to neutral there for me, Sal. The next position would be side-to-side motion, which is where I have the patient take their ear and touch their shoulder. And the thing to watch out for is sometimes patients, particularly in older patients who have some arthritis of the cervical spine, they may want to compensate by elevating their shoulder or scapula up to meet that. And that's really not lateral motion. We're looking purely for side-to-side motion. This, again, to review your plane, is a coronal plane motion, whereas flexion and extension is more a sagittal plane motion. The last motion that we want to look at is rotation, and that's where I have the patient bring their chin over as far as they can over their shoulder. So for Sal, he's got pretty good. He almost obtains full 90 degrees. I'd estimate that at about 80. I'll have him compare it to the opposite side and go to the opposite side. Again, always comparing it to the opposite side. That's why we have two of them. Come on back to neutral there, Sal. So those are the three planes of motions in terms of the cervical spine. The next thing would be to go down into the thoracic and lumbar spine. Thoracic spine is fairly interesting in the fact that it has very limited range of motion. And the reason why it has limited range of motion is because of the orientation, if you remember from anatomy, of the facet joints or the zygoapophyseal joints. These joints are what helps articulate each portion of your spine together. In the thoracic spine, the facet joints are oriented in a coronal plane. So that means that motion through the thoracic spine is fairly limited in terms of flexion and extension. And in fact, one of the best motions that you're going to get is side-to-side motion. So I'm going to have Sal bend in the coronal plane side to side. And you're going to see that he gets good mobility in the coronal plane in lateral flexion side to side. So that's an important thing. The other thing to highlight with the thoracic spine is it also is the origin of the ribs. So we're going to start out by palpating. Sometimes it's easier, particularly in robust or muscular individuals, to start out on the side and palpate a rib and then work your way more medially and posteriorly. As you do this, note the course of the rib, because the rib actually goes cranially as it goes posteriorly, and as it comes inferiorly and laterally, it'll then course. Turn around for me, Sal. It will then course back slightly upward again cranially. So it has kind of a downward and then back upward course. Go ahead and turn around. The other thing that you want to observe in patients, particularly in adolescents, would be scoliosis. And one way to highlight this would be to have patient go ahead in full flexion. So I'm going to have you bend over. Sometimes this is referred to as a skyline view, and I think we're all familiar with this going through school examinations. And basically what you're looking for is that the curve of the spine is very much in the sagittal plane. If you see any coronal plane, which is side to side, as well as abnormal rotational motion, we sometimes refer to that as scoliosis. And you would see that sometimes indicative of one shoulder being higher than the other. So somebody might come in and they'll have a scapula that looks like this, may indicate to you or be a good screening test that they may have a spinous scoliosis problem. Go ahead and stand back up for me. Moving our way down, move into the lumbar spine. Some of the things that you want to do in inspecting the lumbar spine will be looking for something called a fawn patch or a tuft of hair. This is significant in some patients because it indicates spina bifida. And usually when you just have a small tuft of hair, that may be a spina bifida occulta, which means a little defect in the posterior arch of the spine. The motions that occur through the lumbar spine are once again flexion. Go ahead, Sal, and bend forward for me. The orientation of the facet joints in the lumbar spine are in the sagittal plane. So most of your flexion and extension is going to occur through the lumbar spine as opposed to the thoracic spine. And then I'm going to have Sal bend backwards and extension, once again noticing how well he excurses very well through the lumbar spine and extension. The other plane of motion is rotation. And rotation is a transverse plane motion where I'm going to have Sal just rotate his arms side to side. And this is rotation that's occurring through the lumbar spine. Somewhat limited, but not as limited as coronal plane motion. And I want you to pay attention to the lumbar spine down here and just have Sal bend side to side for me. Come back to neutral and just bend in the coronal plane. That's lateral side flexion. You're going to notice that once again most of that motion occurs through the thoracic spine. His lumbar spine doesn't bend that much in the coronal plane. Let me have him come to the left side just to get a comparison. And you can see he does that fairly well, but most of the motion's occurring in the higher lumbar and thoracic spines. So I just wanted to review with you then kind of all the points that we talked about today. With physical examination maneuvers, go ahead and turn around, Sal. The things that really are important, I think, are to go through a systematic way of physical examination. With each thing that you do, I think inspection is very important. I tend to watch patients, particularly when they're dressing. If it's just their coat, it could be just their shoes and socks, but it really will give you a general idea about their function. Number two, we talk about range of motion. And as I mentioned, function, just watching them will help you with their range of motion. Number three is final palpation, and palpation is very important, and particularly knowing your anatomy, because without knowing your anatomy, you're not going to know where each of these structures lie to palpate them appropriately. The next would be to do your planes of motion. Know your planes of motion so that when you describe them to your colleagues, they're very familiar when you're talking about your sagittal plane, coronal, and transverse plane. Finally, when you finish your examination, washing your hands, just when you start the examination, really is practicing good hygiene. Therefore, on behalf of myself and the Department of Orthopedics and Rehab, as well as Sal, our model here, appreciate him taking his time out today, and the rest of the staff here at Loyola, I want to thank you and good luck.